bad debulking strategies by me, and I welcome your thoughts on some of what you're going to see in these two cases. I have no disclosures. It was a very nice algorithm, if you wish, by Patel and Annapurna Kinney and colleagues on what to do. This is obviously very general, and I think what we've seen, and there's no way I can come anywhere near the discourse that we just had from Dr. Matthew on debulking strategies, but this kind of gives you an idea, and I think is a reasonable kind of initial algorithm, if you wish, that you can follow. We know from data that I already showed, but very briefly we'll show again, that all-cause mortality is markedly increased with heavy calcium, and in particular in the left main. If you have a heavily calcified lesion in the left main, 10-year mortality is quite high, 41%, and actually, interestingly, more so with bypass surgery than with PCI. And imaging is what we're talking about. This is just an example of the difference that intravascular imaging makes in left main PCI, and obviously more so in heavily calcified left main PCI. So I'm going to show you a couple of cases. This was an interesting one that I had about 3 years ago. And I guess I wonder if I could get some quick comments on this from the podium.
This was 3 years ago, prior to IVL release?
Sorry?
Sorry, were you asking for comments?
We had, yeah.
Yeah. Was IVL available at this time?
IVL was available at this time. We had off-label, or if you wish, special access use of IVL since about 2019. One of the first cases that I did since it was available.
And there's proximal ulcer/aneurysm. Is that originating from the proximal LAD, not at the ramus?
I think it's actually, so I wonder if I have another shot here. No.
Okay, so more at the proximal LAD.
Yeah.
I'm happy to jump in. My initial approach to this would probably be to use an innate French system and use a sleeve technique to do atherectomy on both sides, and then finish with IVL on both sides. Okay.
Well, 3 years ago, I was not quite as sophisticated as this. So we obviously wired both lesions. We were able to cross the LAD with the wire and pre-dilate it, and this is what it looked like after pre-dilatation. I guess there's some kind of an aneurysm here, or pouch pocket of some kind, that you may see better in some other views.
And at this point, definitely not a surgical candidate, right?
Definitely was not. No,
okay.
Definitely was not.
Because it's hard for us to stop.
Before this, he was not a surgical candidate.
Sure.
So usually, most of my left main patients are surgical referrals, are referrals from surgeons or patients who surgeons have turned down. So it's interesting, you know, we're told we shouldn't be doing left mains, but we're doing the toughest left mains that there are, right?
Absolutely. There are certainly still cases that we have patient preference really asking for left main, but it's important to know that, you know, if they're not deemed surgically ineligible, this is still a perfect time to call out to the surgeons to rediscuss.
So this is a 3.5 shockwave balloon. The first run at 4 atmospheres. I know Ziad said yesterday that it doesn't matter whether you 4 or 6. I'm not sure if I 100% completely agree with that, but I could be wrong. But I find that the 6 sometimes works a little bit better, or maybe it's just because I've done more pulses, so maybe it really doesn't matter in the end. So this was the first, and this was after one of the last runs of the IVL balloon I believe I did the total of 80, and this is what we see afterwards. I'm going to speed up this a little bit. As you can see, there is a fair bit of calcium everywhere. I guess I'm not really speeding it up. There we go. Not too
Lumen is
bad
open.
here, and now we come to the meat of the matter here.
Yeah.
Thoughts at this point?
It looks like a protruding nodule. It certainly looked like it was cracked and disrupted the calcium, and certainly reasonable to, consider that this is going to expand to an NC. I have a low threshold to just use an NC to confirm before I put in the stent, but have you been able to also image the side branch of the ostium of the circumflex?
I did not image the side branch, but I'll show you some of the angiographic images here. So side branches are still good. Nice expansion in the circumflex of the
That's just a straight NC balloon, not the
That's
IVL.
a straight NC balloon.
Yeah, that's great.
Yeah, straight NC
Yeah.
balloon. And this looks pretty good as well. That's a 4.0, I believe, NC balloon. And so I think I'm actually looking pretty good. I'm happy with how my ostium looks, and I'm actually considering that this is probably going to be a reasonable provisional technique, and so that's how I proceed at this point. I think we probably did possibly another run here.
That's
So
a really,
that was the
that's a really
stent
great
deployment.
point
That
right
was the
there.
stent deployment and then POT. This is the POT, post-stent deployment.
I just wonder maybe for a moment in our panel, who would have just jumped to DK crush there because there was an NC prep of the side branch versus keeping this as provisional? It did look very good angiographically.
Now I would go for provisional. When I was a bit younger and I was on the wings of Dr. Dzavik, when I came back, I would have done a DK crush. But I'm not saying one is better than the other at all in these settings. But if you get such a good result with vessel preparation, and if you can avoid the side branch stent, I think you can always come back and do a side branch stent, if there's a TLR in that area.
I do differently. I do go with a two-stent strategy. I think the circumflex is important. The circumflex has a lesion, tight lesion. I would go for a two-stent strategy upfront.
I would go for a two-stent.
I appreciate your comments, and they're totally right on. And and I'm a DK crush guy, right? Like I breathe DK crush. That's what I like to do. My other concern was the trifurcation, was the other side branch. I thought it all looked pretty good, and I could get away without putting a stent in the circ, potentially compromise the large side branch that comes off very early. And so that was my thought.
Sometimes if you just only work on the circ, though, that OM gets pinched, you can
Yeah.
kiss at that point,
Yeah.
and you at least have control. But if it gets pinched after this initial LAD left main stent, then it's going to be hard.
So this is after POT. I guess you didn't see that, but this is even more after POT. And I could not, for the life of me, get a balloon into that rewire or get a balloon into that circumflex. It was just, and I think what happened is I pushed that nodule, calcific nodule, right into the ostium. So to me, the moral of the story is I should have done more techniques. I probably should have rotated both the side branch and the main vessel, and that might have prevented this, is my thought, but like your thoughts on it.
Thank you for showing. I mean, these are real cases, and this is real life, and these things are hard. You're trying to do the best you can to avoid excess metal on the carina. I think this really illustrates the challenges of a nodule and the shift, in that it doesn't really redistribute longitudinally. It's going to fully shift into the other carina. But I think in hindsight, do you think a DK, hindsight is always hard, not real, but do you think that a DK crush approach would have been successful in this case?
My concern is that I would have pushed the calcium into the side branch stent and crushed it in the same way.
Oh, okay.
That's my
Have you seen that happen?
I have not seen that happen, but I have not done it in the context of a calcific nodule. So interestingly, he had no symptoms, no ECG changes, and no troponin rise. So this is how we actually ended up. Now, this is a 76-year-old Hindi man. I don't think all the speakers are here, so will you permit me to show one other case? Yeah.
Yes, please do. We'll extend a few more
Okay.
minutes. Thank you.
So this was a 76-year-old Hindi-speaking man. I see a lot of Hindi-speaking men in my practice in Toronto. There are about probably 500,000 of them, and they're all high risk for coronary disease. He, in addition to being that, had CKD, type 2 diabetes, had cirrhosis, presented a month ago, and I literally mean a month ago because it's a recent case, with an NSTEMI. His EF was 60, and he did not wish to have bypass surgery. I'm not sure why this is not. Oh, that's why, because I had forgotten to make movies, so those are just stills of the initial. So those are, if I go back to, I don't need to. This is, you see as much as you need to here in this LAD. So this was with a Xi'an blue wire, and then I believe we could not cross that mid lesion with any balloon. So what we did was with a Turnpike LP, which interestingly did cross, we exchanged this out to a rotowire and proceeded to do rotablation with a 1.5. This was a result, then a 1.75. And this is what we had after all of that. So now you're seeing the caudal view showing the severe intermediate lesion. We now wanted to focus on that and had a lot of difficulty actually. You see here on the left my attempt to cross with a 1.5 balloon and how it backs out the guider. So eventually with better support, I was able to actually cross with the 1.5 and dilate with the 1.5, then a 2.0. With the 2.0, I had balloon rupture, and basically hemodynamic collapse, pressure went to the 40s, requiring high-dose levo and a bolus actually of epinephrine, which worked out very nicely. This is his angiogram after the epinephrine. I would usually give half an amp rather than the full amp because it's less of a traumatic effect on the patient. It usually works quite well. And so now we were able to proceed. So we had him on levofed at 0.2 per kilo per minute, little boluses of phenylephrine as well. And so we pre-dilated some more and then deployed at 275, 38. Onyx, this was a result after that. So that, this you see higher pressure inflation with the balloon being removed a few millimeters. So the stent actually did not reach the diagonal branch. Now we pre-dilated some more. This is now focusing more on the circumflex, which I was now able to pre-dilate better. I think there was a bit of a granatoplasty with that 2.0 balloon, and deployed at 2.5 by 22 Onyx, then pot crushed it. So in other words, a crush just at the carina that is done with a balloon sized for the main vessel. Okay, that's an option you can do rather than crushing with a balloon for the LAD and then going with another pot balloon. So this is a technique I sometimes will use to do that instead. Then we recrossed, and now having prepared the side branch, actually deployed a 4.0 by 38 Onyx. And here I show kind of where I like to have the pot balloon on the left, and the second image on the right is where I had done an initial image and then pulled back to ensure I expanded the ostium as well, if the balloon is shorter than your left main stent. recross, final optimization after IVUS of, with a 3.5 in that distal segment, because that's what the IVUS showed it to be. I'm not showing that, but it was completely optimized, 3.5, then 3.75, and here's our final result at the end. But I think I probably could have handled the side branch a little bit better. So this is the theme, is the side branches here. Rather than pushing on with a 2.0 balloon, I wonder how you might have dealt with that, whether it be ROTA or some other technique.
Thank you again for this case. I think it just shows both of these cases, when there is significant calcium at the bifurcation, you're in for a fun experience. There's a lot to do. I think with the sleeve techniques, and then also I think the other thing is when you have a large lumen, even after rotating the LAD, you can just pull that wire and move over to the other side branch. And sometimes we fear that, but the vast majority of time, there's plenty of flow down that first branch that was atherectomized. And
Do you mean the diagonal wire?
the ramus.
Okay. So the diagonal wire, that's a good
Yeah,
point,
yeah,
because I
yeah.
had trouble pulling that out after, I should have pulled that earlier than I did.
Yeah.
And I had considerable difficulty pulling that wire. I have a case report from 15 years ago where that didn't go so well. Thank
Well,
you.
thank you very much.
All right.
If you want to summarize. Yeah.